Okay, good afternoon, everyone. My name is Lexi Weiberg. This is our second COVID-19 webinar to go over some updates that have happened throughout the last week. We'll be having Crescent Beavers, our risk adjustment manager, speaking on some of the telehealth updates. And then we'll also have Barbara Mueller, who's our strategic programs manager, go over some of the different platforms and things that we have been working on for you. We're going to start out the webinar with our CEO, Anwar Kazi, giving a brief message and an update to you from him. So Anwar, you have the floor.
Hi, everybody. Good afternoon. Thank you for being here today. I'm honored to be talking to the folks who are the real heroes here in this unprecedented international crisis. I'd like to take this opportunity to inform you guys of all the things that we at Premier are doing. Obviously, with everything happening so fast and the crisis turning out to be the way it is, and not really knowing the end of it at this time, we are going to try our best to make the best of it, working with our partners like yourselves and others, and drive as much benefit as we can towards you. As you saw from our letters that we've been communicating, we are trying to solve one and only one problem at this time. We knew when the crisis started that the economic fallout of all the patients not coming to the practices, folks being asked to stay at home, among other things, will have a dramatic impact on our provider practices and their incomes. As an example, we estimate that our providers sit on not more than 27 days of cash flow. That means that if they have maximum of an average 27 days of cash in the bank, if they don't get checks coming in from the insurance companies and they don't sustain a certain volume, for them to keep the lights on becomes ever more difficult. So my quick couple of minutes of talk here will focus on three things. In fact, just two things. Well, the first thing is the health issues around this problem. I'm not going to debate about this or talk about this at this forum, as you guys are much more proficient and knowledgeable about the health impact and the solutions around this issue and where this is headed. I'm going to focus on two other issues, which is the economic issue and what Premier is doing, helping you guys stay or keep your heads above the water. So, majority of our practices in North Texas are seeing anywhere from 20 to 30% volume in their practices, and most of them have now chosen a virtual solution. It could be as simple as a telephone or making phone calls to the patients, to some sort of a hybrid of Skype and FaceTime, to a telemedicine solution of different sorts through their EMRs or independently. And we are very, very happy that this is happening. And we encourage you to continue to pursue any means necessary and take full advantage of the waivers extended by the government around these solutions for now. People ask me how long these waivers will continue. We believe that since the emergency has been declared, the emergency normally extends up to 4 months. So we are looking for another 3 months of this continuing, and after that, we do believe CMS will start reverting back some of the waivers that they have extended, possibly, and that means that you will need to move to a platform which is HIPAA compliant, among other things, and integrates well with your EMR and other things. And I'll talk about that in a second. The economic issue, in our belief, is that there will not be a back to normal situation anytime soon. The impact of what's happened today in the marketplace is very deep, and we will see dramatic changes in the healthcare industry, and we will see dramatic changes in the economic environment of the country for a couple of years to come. Specifically in the healthcare industry, the hospitals are already claiming that they are seeing a loss, or will continue to see a loss when this whole thing plays out. About $1.4 trillion. They're projecting a loss of about $1.4 trillion. So they will tap into those funds that we all keep hearing about from the Senate and Congress, and they will drive those dollars to keep themselves afloat. We also believe that the insurance companies are today under pressure with the waiver of all the copays and among other things, and they will raise premiums next year. Also, the last thing we see is that because of the unemployment situation getting from bad to worse so quickly, that the bounce back of the economy will not convert into the bounce back of people getting hired very fast. So we see that next year there will be somewhat of a decrease in commercial volume for our practices, hence for the importance of senior lives as we go forward. So short term, like I said, we encourage you to get going with any telehealth solution that you can find, starting from phone to Skype to FaceTime or any other telemedicine platform that you have. We are working with the federal government programs to tap into incentive dollars for you. We also got to go ahead from some of the payers in some programs to drive advanced dollars to you guys in quality programs and others. We are true partners with you, and we will true up those numbers at the end of this year. But we want to drive some dollars to you right now as you try to stabilize the volume in your practices. We are also immediately energizing some existing ancillary programs to pay more from next month, like CPL, and we are also energizing some of the ancillary programs like Premier RX discount card, which was in the pilot phase with some of the practices. We are energizing those ACO-wide, which pay you $350 per month per provider. And then we are also been working with you for the remote patient monitoring program, which we encourage you to work with us as this becomes a part of your virtual practice going forward, and brings dollars to you today and keeps the patients healthy and at home. We are, as a short-term measure, we are also working with a couple of major payers to drive fixed dollars per patient per month to our providers. We have not gotten a go-ahead from a major payer in the community today, but we are trying our best, and we are presenting to their leadership again on Monday next week, and hope we can get something going. So that's these are the short-term measures. In the medium to long-term measures, we believe that a certain percentage of your practice will now remain to be online. Like I said before, we don't see a back to normal situation. So we believe that a certain percentage of your practice will remain online. And we want you to, at that point, have a telemedicine solution, which is obviously all compliant, integrated with your EMR, and then also backed by a central business office for appointment scheduling and pre-auths and other things. And that's a whole business model that we will talk about separately. Barbara is going to touch on that a little bit today, but it's a standalone separate discussion that we should have. We also, like I said before, believe that there will be the patient mix will become less commercial next year. And also with the commercials which remain to be in place, there will be higher copays, among other things, as premiums go up, and the focus on seniors for your practices. The percentage of income that the seniors bring to your practices will become ever more important. So in that format, Premier is going to work with you to continue to increase your shared saving bonuses and drive bonus dollars to you in your quality programs and others. So these are the short and long-term measures that we are taking. Some of the things that Premier is bringing to you today as a platform to help you, starting with these Thursday webinars. I will be on these webinars with my team, who will walk you through all the technical aspects of different things, starting from telemedicine to other things. We will be sending out weekly emails from my side. Some of these emails will contain some of the things that we just talked about, and I'll keep you abreast on all the progress. More so, starting from myself to anybody in Premier Management Organization is available to you for any one-on-one meetings as we talk and discuss and debate about your customized needs. Every practice, a lot of people have been calling me to discuss about many different aspects of their practice, of their issues and their situations. We are more than happy to discuss, debate, and bring anything that we can from our arsenal to help you guys and see you guys through this really difficult period. Also, like I said before, we are at this point bringing the funding through advanced quality payments next month, and the enhanced quality payments next month, so that those checks are coming to you next month. We are working with the federal and state governments to find incentives for you. We have approached the government already to find a ACO-wide incentive program for our providers, and hopefully see if we can find folks there who are interested to talk to this large community as a whole. And like we talked about, working with different insurance company and payers to drive incentive dollars for you. All of this combined is what Premier is working every day. We have the whole company comes together every morning at 8 a.m. All the leaders come together on the phone and discuss about the things that we are doing to contribute to and help you get through this difficult time. But more so, like I said before, we are willing and able to get on the phone and talk to you guys about any customized needs that you guys have, and hope to help you through this difficult period. Thank you so much.
Thank you, Anwar. Now we are going to go on to the next slides, and Crescent Beavers, our risk adjustment manager, is going to be presenting that. Also a reminder, you can put any of your questions in the chat, and we will go over those at the end and get those answered. Thank you very much. Crescent?
Good afternoon, everyone. Thank you for joining our second COVID webinar. Just wanted to start out with a couple of new things that are coming from us here at Premier. We do record these webinars, and we have set up a YouTube site for viewing these if you need to go back and reference any of the material that we talk about, or if there was something that you missed and needed further clarification on. You'll see here that our first webinar has already been posted. So do feel free to go and review that webinar if you have not had a chance. Hopefully we'll be addressing some of the questions that have come up here recently and get all the answers that we need to get out to you. As always, continue to use your PBEs for continuing to contact via GTM and emails and telephone calls. And like Anwar said, we're all available to you. I know that a lot of the times that the only time that you get a moment is in your lunch hour, which we don't want to take up all of your lunch hour for this, but if it's after hours, I'm available if you need me, or any of our staff, I believe, would be willing to have any discussions that you may need for those questions that may arise in between our webinars. Next slide, please. So new information that has come out on the 23rd of March, Humana did release their new expanded coverage for telehealth services with the clarification on telephone communications for those patients. that we will be providing at the end of this webinar a complete list of helpful resource websites that you may access to get very detailed information from the payers. We update that as often as we do see those updates. I do want to stress that these updates not only come daily, but come hourly and may change at any given moment. So we try to keep that up to date for you with the most up-to-date information that we have. One of the things that has been reported from payers is that providers are sending their patients to a Quest or LabCorp draw facility. They are not doing blood draws at these facilities. Blood draws do have to be blood draws or nose swabs for testing of any kind for any kind of lab work must be performed in the provider's office or in a healthcare facility or at a designated testing site for COVID-19. We are also asking providers to, at minimum, hold your claims that are related to COVID-19 until April 1st. A lot of these payers have not been able to update their software yet with all of the new diagnoses and CPT codes. The majority of them will start accepting claims as early as April 1st. Some may be sooner. I have reports that Medicare is denying them at this time. They are one of the ones that said April 1st is when they would be able to accept claims. And I know Blue Cross Blue Shield is not accepting claims until April the 6th. So at minimum, please hold your COVID-related claims until April 1st. Next slide. So we've come up with a new billing tip sheet since everything has rolled out, and with the changes, we're trying to get everything on one page at a glance for you so that you can see our major payers and be able to get information as quickly as you can without having to go to all of these resources. So all of the Medicare, Humana, Aetna, Blue Cross, and Cigna plans are covering the testing for COVID-19. Those copays and cost shares are waived for these. Telemedicine services are all being utilized with the exception of Blue Cross Blue Shield. The latest that we have for them is that they are only covering the two-way live interactive phone or digital video only. We have not been able to find any information that they are covering telephone calls at this moment, but we are still working to see if that has changed for them. For your unrelated services with Blue Cross Blue Shield and Cigna, those are subject to copays and deductibles. And for Medicare, it is up to the providers on whether they would waive services that are unrelated to COVID-19, but they are covering anything that is related to COVID-19. For providing these services, it's still the same as if you were seeing these patients in your office as a face-to-face visit. So whoever is able to bill for that normal E&M code is who can bill for these telemedicine services. If you have patients that are calling in and nurses or MAs are just refilling medications, that is not something that is normally reimbursed. Those are not billable. So all normal services that would normally be billed by a provider or a practitioner are the services that are covered and are billed out. Pre-authorizations are not required for most of the services that are going on during this emergency plan, with the exception of Humana is wanting to have pre-authorizations for post-acute level care. And Blue Cross Blue Shield advises that you check eligibility and benefits through Availity on all patients. A lot of their commercial plans are funded through private employers. They all have different plans on whether or not they cover telemedicine or not. Those rules still apply for those patients that are on those commercial plans. Claims processing. at this time, the only one that we have heard back on the processing times is through Humana. They have stated that they will continue to run as usual. We do anticipate that there may be some delays as the new codes are being loaded into their system, but for the most part, we do anticipate that claims processing runs will run as usual with each payer. Required modifiers. Medicare has stated that modifiers are not required for your billing services. I actually recently saw a new update today for things that are unrelated to Medicare. And like I said, this is something that updates every day, and we will get this posted out there for you. For unrelated services, they are requesting that they have the modifier on them. Humana is saying to add the 95 on all your telemedicine. Aetna has not provided any information regarding the modifier. Blue Cross Blue Shield, 95 modifier for telemedicine, and Cigna MA is saying that they are not requiring any modifiers at this time. Place of service codes for all telemedicine services is 02. I know there has been lots of questions out there about how do you get that place of service on there. Most EMRs are set up currently that when you do an office visit, it defaults to place of service 11. So that may be something that you need to reach out to your EMR companies or your liaisons, your contacts there, on asking them how do you go in and change that place of service for telemedicine when we're just now learning all of these new aspects for these EMRs. It may be something that you have to turn on in the background to be able to have that option to change that place of service. And then we talked about accepting claims beginning on April 1. Humana and Aetna and Blue Cross Blue Shield. Sorry, I misspoke earlier. It is Cigna that is April 6th, but all the others is April 1 and possibly sooner for your private payers, with the exception of Medicare. Next slide. So I wanted to go over some documentation guidance. Here we are a week into this, starting this afternoon and tomorrow. I will be going in and doing some auditing on your notes to make sure that everything is being captured like we need to on our notes, that if we need to change anything, that we roll out that to you as quickly as possible, so that we're making sure that we are adhering to the documentation guidelines that have been set forth for us. E&M documentation guidelines is your standard guidelines, with the exception of making sure that you have your stop and start times in your visit note for these telemedicine calls, especially the ones that are on the telephone, that you're actually calling a patient, or you're doing one of the alternative methods of FaceTime or Skyping, that you have that time noted, because these are time negated visits. I've put some tables down here at the bottom for you so that you can see what those times are for each of those codes, and we'll touch on those here in just a moment. Patients can have telemedicine and telehealth visits that are not related to COVID-19, including their wellness visits, can be performed. The only aspect to that wellness visit is that with the telemedicine, there are things that cannot be done for that wellness visit. Physical exams, vital signs, lab testing, those are some of your quality measures. So these patients will have to return back into the office later in the year after this emergency order is over, so that we can capture those quality measures for you and make sure that everything is covered for the end of the year for your quality measures. So going back to table 1 for your E&M diagnosis or CPT codes that are time-based versus bullet pointed, you have your new patient visits that are listed there. the time spent for those, and your established patient visits and the times for those. For providers that are using patient portal video conferencing in Table 2, these are cumulative over a 7-day period and can only be billed once every 7 days. So if you see a patient video conference today and you spend 10 minutes with that patient today, and they call back tomorrow and you spend 7 minutes with that patient tomorrow, and that's the only 2 times that you see them in that 7-day span, then you would bill out that second level 11-minute to 20-minute code. You need to make sure that we are not billing for each encounter, that these are cumulative over a 7-day period for your patient portal video conferencing. Virtual check-in telephone calls, these are your brief 5 to 10-minute medical discussions with your patients. These cannot be originating from a related service that was provided to the patient within the previous 7 days, nor leading to them coming in within the next 24 hours or the soonest available appointment for the same condition. If those patients do come in within that 24-hour period or the soonest available appointment, the G code would no longer be accepted and you would go for your E&M coding for those patients. And we do ask that you please refer back to the links that we are going to provide for you at the end of this webinar for any guidance on usage of modifiers. Modifiers are specific to the type of teleservice platform that you use, via telephone, via web-based through a patient portal, or if you're using Skype or FaceTime. There are different modifiers for each of those, and you need to make sure that you are looking at your payer-specific guidelines for this. Next slide. And before we move on to Barbara, I do want to just make sure that we stress to our providers that all of these rules are temporary for this emergency order. Telemedicine is not something that is generally covered for Medicare and Medicare MA patients. This is just temporary, and all the rules that are in place now are for what we speak of in these webinars, but the rules will go back. And at this time, we have no further information from CMS saying that these will be covered after the emergency order is over. So with that, I will turn it over to Barbara Mueller.
Hear me? Okay. Thank you, Crescent, for that. And yes, just to reiterate what she said, we have been working on different telemedicine options here at Premier, but just knowing that a lot of these exceptions are during COVID-19 emergency, and we don't know what will happen. Coverage could just go back to being how it was before. So just wanted to review real quick the virtual options that we currently have, and Crescent has done a great job going over the different codes. So right now, for the emergency telephone, is a great option when the patient does not have video capability. It's not HIPAA compliant, but those violations are being waived during this time. And of course, it's free for the patient and the practice. E-visits and virtual check-ins are covered, and this is only for established patients. Moving on to Skype and FaceTime, also free options. It's great when a patient has that video capability and they can do that. Also not HIPAA compliant, in telemedicine, e-visits and virtual check-ins are covered for established patients only. One area that has been growing in the past couple of weeks is that telemedicine platform. So in addition to all the things that telephone and Skype offer, it also offers additional functions. So things like patients can self-schedule, virtual waiting rooms. Some have ability to collect payments those types of things. They're usually pretty easy to use. There are some free ones, there are some that cost money, but the great thing about this option is that it can be used for new or established patients. So if we go to the next slide. So Premier has been working hard the last couple of weeks on coming up with some telemedicine options for our providers if they're interested in pursuing them. So we've been vetting various telemedicine vendors, and these are the 3 that we're currently getting to the end stages with. Starting with VC Telemedicine. If you all are familiar with Doxy.me, I know a lot of our providers have started to use the free version. VC Telemedicine is pretty similar in that it's an easy plug and play platform. You contact them, you tell them you want to get started, and they form a website for you. Your landing page for their platform is the name of your website, and they can do a lot of things to personalize the workflows. With the contract that we've been discussing with them, the cost to our providers would be $50 a month per provider with the implementation fee waived, because Premier would pay as an entity instead of per practice. In this type of option, the practice manually enters the patient into the portal. This is perfect for those that maybe don't want to use that free version, want a little bit more for a few months, and want to get started today with low overhead. It's a good short-term solution to a short-term problem of COVID-19. The next option that Premier is working on for our providers is the NaphCare telehealth and telemedicine solution. So NaphCare is something that's already offered through Premier. We started the contract earlier, actually at the end of last year, with NaphCare for remote patient monitoring and CCM services. We have started doing some demos for providers, but it's understandable that right now providers are more looking towards that telemedicine option due to the situation. What we were able to work out with NaphCare is $30 per provider per month with no implementation fee. And then vendor could load the patients into the portal to save the practice time at an additional cost, or the practice could just type in the demographic information themselves. This is really perfect for practices that would like to bundle telemedicine and the RPM and CCM services. The big benefit with this is because they already are an easy vendor to work with for those telehealth type of services. This is something that would bring additional revenue to the practice. So the practice could do the telemedicine option long or short term, like if coverage stops, the telemedicine option could stop. But RPM and CCM through these are already covered and have been covered through CMS, and we're looking into the other payers for details on those. So that would be something that could continue the telehealth part as additional revenue for the practice even after telemedicine is over. And that contract is being finalized at the end of this week. The last option that we have is Touchpoint Care. So not too much information on this one yet. Anwar spoke to this earlier when he was introducing the different options we're working with. This would be perfect for practices who want to bundle telemedicine and centralized business office activities. This is still under negotiations, so more to come, but this would be more of that long-term solution for centralized business office activities. Next slide. So lastly, I wanted to review the ways that practices can currently substantiate income through the different programs available through Premier. So the first ones are just the payers that we currently have, and it has details. I won't go through each of these because you'll receive these materials, but it just goes through a description of each program and the payment that providers who are enrolled in this would receive. So for example, Humana MA for providers who are enrolled, there's a monthly engagement payment, $250 PMPM plus times the provider's engagement score. And then there's quality bonus payments up to $715 PMPM based on quality measures met. Aetna is similar. Cigna is actually one where we are expanding it due to the situation. So we didn't used to pay an engagement fee, but that is going to be starting $250 PMPM times engagement score. and they're a contract for us that has been growing, and they're accepting opt-ins right now. And lastly, for contracts, Blue Cross Blue Shield commercial for first year enrollment bonus with limited availability as of now, and an annual payment PMPY. Other vendors that we work with that have opportunity for revenue are clinical pathology labs. So for this one, the payment model is being finalized and more will come, but it is our preferred lab vendor, limited availability. So please ask your PBE about their requirements for participation. Premier RX card, this is pretty easy to use. It's a discount card that the provider can give out to patients for pharmacy. Regardless of income, insurance, citizenship status, any patient can use this. The card group number is linked to the practice with a specific URL built for the practice. No additional cost to do any of that. And providers may earn up to $350 per month. The next one is NaphCare remote patient monitoring. So this is the one that I was referring to earlier. They're already our exclusive remote patient monitoring and CCM vendor, and they are expanding their platform for telemedicine. So for this one, practices could choose to sign up just for the RPM part, or for the RPM with telemedicine, or sign up for RPM telemedicine and then end the telemedicine once it is no longer needed. And then lastly, we have Encompass Home Health. This program has been around for a while, but it's our preferred partner for home health and hospice services. And this collaboration gives us a lot of insight into the patient's healthcare costs and quality, along with some revenue sharing for ACO programs. So I know I just went through this really fast for the sake of time, but your PBEs can tell you a lot more information about this and get you connected to the right contacts, even if you just want to learn about whether you qualify for participating. The last call out I should have said at the beginning of this was, I know we have providers from Premier, but also from other ACOs joining us. So these programs are not available in all markets. These programs are currently only available in the DFW market. Thank you. Okay, great. So that's the end of our presentation. We are going to have an open forum. Please use the chat to ask any questions that you might have. And we do already have a question. Kathy Parisi asked that you said to hold COVID claims until 4/1, but what about any telehealth claims without COVID diagnosis codes?
Any claims that are not COVID-19 related can go ahead and be filed out. It is just anything that has a COVID-19 diagnosis on it or is related to COVID-19, they are asking that you hold those until April 1.
Are there any more questions? Okay, great. Well, we will send you out the link for the recording of this, and we'll also send you out the materials today about any of the different things that we've gone over. Okay, let's see. We've got a few more questions. So from Dr. Oglu, we have, for the video televisits, can we bill with regular E&M codes like 99213?
If you are using any of the other platforms other than a patient portal platform, yes.
So Kathy Parisi says they're denying Medicare is denying anything with a non-diagnosis COVID claim. So we can check into that for you and see if there's any update on that.
Example from that you had sent in, Kathy, and I will be checking into that for you. There has been a couple of questions that have crossed that I wanted to address. One was, what kinds of prescriptions can physicians do via telemedicine, specifically for chronic pain treatment. Chronic pain treatment is allowed via telemedicine until April the 10th currently. Refills for these medications can be done via technology as long as there is an existing doctor-patient relationship, and it does not have to be, of course, related to the COVID-19 diagnoses. They are saying that it is still required that you do a PMP check for these, for your opioids, benzos, and barbiturates, as in compliance with any other chronic pain treatment.
Okay, so Kevin Jackson asked for e-visits 99421 through 23. You mentioned a portal video service, but online I see a lot of mention of secure emails. Does it need to be face-to-face?
Your secure emails are part of your, if you are not using a patient portal for that, if it is coming directly to your email, that is considered part of the covered services for your regular E&M billing, as long as you are documenting like a standard E&M visit, like you had a face-to-face conversation with that patient.
Okay, next question, Dr. Chandra asks, are all insurances waiving copays and deductibles?
No, they are not. They are payer specific and are generally related to COVID-19 diagnoses that are being waived. Other visits for other sick visits and wellness visits are subject to copays and deductibles and coinsurance.
Okay, do you know about payers slowing down regular claims processing and payments? We are getting some complaints.
I have not heard anything on the slowdown process. Currently, the only information that I do know is from Humana saying that their claims processing will run as usual, with the exception of the delay in loading the COVID-19 covered diagnoses and procedure codes that are new to the system into their systems. And that's why they have asked for the delay of submission for April 1st.
Any more questions? Okay, of course, if you do have any more questions after this, you can always email your PBE and we will get you that information. Like I said, we will be sending you the link and the materials that were presented today in case any other people need any help or have more questions once watching the webinar. And so we will see y'all next week on Thursday. And of course, if you have any questions in between, you can always give us a call or email, and we will give you updates as soon as we get them. So thank y'all so much for attending, and we will see you next week.
Thank you.